Brainstem stroke syndromes means vascular occlusion of any of the blood supply of the brainstem. We have first to revise rapidly the blood supply of the brain of the brainstem. It is starting as the posterior circulation, the intracranial part of both vertebral arteries, which give a branch to form the anterior spinal artery, the pica, posterior inferior cerebellar artery. Each one of them gives the posterior spinal artery on both sides. So we have one anterior spinal and two posterior spinal arteries. Then the two vertebral form the basilar, which give the pontine branches and also give the superior cerebellar arteries, and then finally divide to form the posterior cerebral arteries on both sides. We mean by the brainstem stroke syndrome occlusion of the blood supply of the midbrain or the pons or the medulla give a certain clinical syndromes. In order to study this syndrome, we have another concept or another view for the blood supply, which is the regional blood supply. This is the V-shaped midbrain. We have this distribution of the different blood supply of the brain, which explain if one artery is occluded, what is the neurological manifestation which will be happened. The most posterior part here in this color is the posterior cerebral artery supplying the tectum and the part beside the central canal. The interpeduncular branches para midline of the basilar artery. The superior cerebellar artery, a mid part behind the tegmentum, the posterior part of the tegmentum. Peduncular branch of the posterior cerebral artery, all this area, and the posterior choroidal branch. This map of the regional blood supply explains if a certain artery is occluded, which part of the midbrain will be affected. The same process also, or the same distribution of the blood supply of the pons. The blood supply of the pons comes mainly from the basilar artery, but we have a certain point. First, the paramedian branch supply most of the anterior paramedian branch of the basilar artery on both sides. And then this basilar artery give a circumferential branches, one on each side, which is the short circumferential branch supplying the next area of this paramedian line, and then a long circumferential branch of the basilar artery supplying the posterior part of the pons. This map is called the regional blood supply of the pons. All are supplied by the basilar artery, but we have a paramedian branch, we have a short circumferential and a long circumferential branch. The medulla. Medulla, we have three levels of the medulla. At the level of the olive from upside down, level of the sensory decussation, and then the level of motor decussation. The anterior spinal artery supplying the paramidline of the medulla nearly in all cuts. Then followed by the vertebral artery branches, nearly the anterolateral part, and then the posterior spinal artery supplying this posterolateral part of the medulla, and then lastly the inferior or the posterior inferior cerebellar artery, which is the pica, supplying the posterior part of the lower levels of the medulla at the motor decussation. So in this simplified diagram of the regional blood supply of the medulla, we have the anterior spinal artery. This is the anterior spinal artery supplying mostly the paramid line. The posterior spinal artery supply a small part in the middle cuts of the medulla at the level of the sensory decussation, while the posterior inferior cerebellar artery of the pica supplies the posterolateral part of the medulla. These levels of the medulla representing the regional blood supply. What about the internal structure? For the midbrain, we have the crus cerebri. The crus cerebri contains the corticospinal and the corticobulbar tracts, the corticospinal tract in the middle, and the corticopontine tract as the lateral part. And then from the anterior part, we have the exit of the oculomotor nerve, and this is the site of the oculomotor nuclei. And we have the red nucleus on both sides, the medial and trigeminal lemniscus behind and lateral to the red nucleus, the spinothalamic tract or spinothalamic lemniscus, and then the nucleus of the trigeminal nerve on both sides, which is a mesencephalic nucleus. Posterior, we have the superior colliculi. This is the corresponding MRI image for the midbrain. What about the clinical syndromes? In each clinical syndrome, it is not mandatory to know the name of the syndrome, but you have to have an explanation why it is happened, okay, and which artery is responsible, and what is the clinical manifestation that results from this syndrome. If you are study more to have a deeper information or to keep the name of the syndrome, it will be a very a good point. First, the Weber syndrome. It is caused by infarction of the oculomotor nucleus and cerebral peduncle in the ventromedial aspect of the brain. This is the cerebral peduncle, and this is the site of the oculomotor nucleus. What's happened by which artery is occluded? This is the most important. It is occlusion of the paramedian branch of the basilar artery or the posterior cerebral artery. This is the cause of this form of occlusion. Oculomotor nucleus infarction of the oculomotor nucleus in the ventromedial part. The patient presents with ipsilateral oculomotor nerve because it will affect the nucleus itself. That's resulting in manifestation of oculomotor nerve palsy, infralateral eye deviation, diplopia, ptosis, and afferent pupillary defect. In addition to contralateral hemiplegia or hemiparesis due to infarction of the corticospinal and corticobulbar tract in the crus cerebri. This is called a crossed hemiplegia or hemiparesis. What's meant by crossed hemiplegia means we have the cranial nerve affection on one side and the hemiplegia on the other side because the affection of the crus cerebri happened at a level higher than the level of motor decussation in the medulla. If the substantia nigra is also affected in this part, the syndrome manifests with contralateral Parkinsonian rigidity as well, because the substantia nigra is a part of the parasympathetic supply. This diagram representing the level of the midbrain shows the area involved in Weber syndrome. This blue area in the Weber syndrome is mainly hemiplegia in addition to oculomotor nerve affection. The second syndrome is the Benedict syndrome, or what's called the midbrain syndrome. It is due to infarction of the tegmentum of the midbrain. This is the infarction of the tegmentum of the midbrain, happened also in what we call Benedict syndrome. It is due to infarction of the posterior cerebral artery, supplying the fascicles of the oculomotor nerve and the red nucleus. The oculomotor nerve extends from this side of the medial to the crus cerebri. So in Benedict syndrome, the affection is affection of the nerve fiber, not the nucleus, in addition to affection of the red nucleus. Also, the patient will have ipsilateral oculomotor nerve palsy in the same side, crossed hemiataxia. This called crossed hemiataxia and incoordination and chorea. This crossed hemiataxia due to affection of the red nucleus. Okay, so this name of crossed means the opposite side of the cranial nerve affection because it is a lower motor cranial nerve affection and the crossed happen to the opposite side. So in this case of Benedict syndrome, we have infarction of the tegmentum of the midbrain, okay, due to affection or occlusion, posterior cerebral artery, and affecting the fasciculus of the oculomotor nerve in addition to the red nucleus. We have only oculomotor nerve on one side and the crossed hemiataxia and incoordination and the chorea on the opposite side, and this is called the crossed hemiataxia. The other syndrome is the midbrain, which is the Claudy syndrome. What's mean by Claudy syndrome? It is infarction of the dorsomedial aspect of the midbrain. Affection of the dorsomedial aspect of the midbrain in Claudy syndrome due to affection or involvement of small perforating branches of the posterior cerebral artery, supplying the medial aspect of the red nucleus, the rubrodentate fibers, and the third cranial nerve nucleus, which is the oculomotor nucleus, in addition to the superior cerebellar peduncle. In this case, the patient will present with ipsilateral oculomotor nerve palsy in coordination and contralateral upper and crossed upper and lower limb cerebellar hemiataxia. This is also can be named as a crossed to the opposite side. So this part due to affection of the dorsomedial aspect of the midbrain, which contain the are supplied by the small perforating branches of the posterior cerebral artery. Okay, the affection also have affecting the ipsilateral oculomotor nerve, resulting in incoordination and contralateral upper and lower limb cerebellar ataxia. This cerebellar ataxia due to involvement of the superior cerebellar peduncle. The pons, pontine branches of the internal structure of the pons. We have these transverse pontine fibers, and in the anterior part of the pons, the pyramidal tract are spurred within or spurred and fractionated in between the pontine fibers, including the corticospinal tract, the corticopontine tract, and the corticopulbar tracts. And we have the medial lemniscus, trigeminal lemniscus, spinothalamic main sensory nucleus, in addition to the motor nucleus of trigeminal nerve, mesencephalic nucleus, and locus coeruleus. This is the central or starting the upper part of the fourth ventricle. The occlusion syndrome, including the following. This is the cross MRI and in a magnification form to match the internal structure with the MRI. This is the ventral part of the pons, the pyramidal tract, and the posterior part is called the dorsal tegmental part. This is the internal structure of the different nuclei, nucleus of the seventh cranial nerve, eighth cranial nerve, the seventh cranial nerve nuclei, in addition to the facial colliculus and middle cerebellar peduncle on both sides. The pons, Mary Fox syndrome or the lateral pontine syndrome. It is due to infarction of the lateral part of the pons in addition to the middle cerebellar peduncle. It mainly happened by perforating branches of the basilar and anterior inferior cerebellar arteries, which is abbreviated as the ICA, anterior inferior cerebellar arteries. The corticospinal, spinothalamic, and cerebellar tracts and the facial and the vestibulocochlear cranial nerve nuclei are affected. This diagram shows the affected part in Mary Fox syndrome. The patient presents with contralateral hemiplegia or hemiparesis according to the extent of affection, ipsilateral impairment of pain and temperature sensation, limb ataxia, facial paralysis, hearing loss, vertigo, and nystagmus. All these are affection or due to affection of the facial and the cranial nerve nuclei. And remember, we have a contralateral hemiplegia and the ipsilateral affection of the cranial nerve. And this is called a crossed hemiplegia or crossed hemiparesis, which means we have a lower motor neuron affection of the cranial nerve on the same side and hemiplegia on the opposite side. The Fuveli syndrome or inferior medial pontine syndrome. This inferior medial pontine syndrome infarction of the bones involving the corticospinal tract. This mainly affecting the corticospinal tract, the medial lemniscus, okay, the medial lemniscus, and the central tegmental bundle. This affection also of this part of the midbrain affecting the paramedial reticular formation, the nuclei of the abducent and facial nerve, 6th and 7th nerve nuclei. It is due to affection of the paramedian branches of the basilar artery in a unilateral manner. Because if it is a bilateral, it will be the second syndrome, which is called the locked syndrome. The patient will present with contralateral hemiparesis or hemiplegia on the opposite side and hemisensory loss, ipsilateral in the same side, facial nerve palsy, conjugate gaze palsy with inability to look to the side of the lesion with diplopia. Why we have diplopia? Due to affection of the abducent nuclei and paralysis of the lateral rectus muscle. So the patient will present also what's called a crossed hemiparesis or hemiplegia, the facial nerve palsy on the same side, conjugate gaze palsy, inability to look to the side of the lesion, that's to say, inability to do abduction of the eye due to paralysis of the lateral rectus muscle because the abducent nerve is affected. This is called the Fuveli syndrome, which is a paramedian or inframedial pontine syndrome, affection of the paramedian pontine branches supplying the medial part of the bones. This example of this Fuveli syndrome, this is the MRI axial, this is the diffusion. We have acute infarction here involving one side of the bones, which is the paramedian part of the bones. The locked-in syndrome. The locked-in syndrome, it is insult to the pyramidal bundles of the ventral brainstem, in addition with paralysis of all voluntary and respiratory muscle, often necessitating mechanical ventilation. This patient is critical and need to be hospitalized in an ICU and have mechanical ventilation due to obliteration of the paramedian of the basilar artery bilateral. Remember, in Fuveli syndrome, we have a unilateral affection of these paramedian branches of the basilar artery. In this locked syndrome, we have a bilateral on both sides affection of the bones, which is a very serious condition. If it is a unilateral, this will be a Fuveli syndrome. What happens? The patient is awakened and conscious with preserved cognitive function. He is oriented, but he cannot speak, cannot perform any limb or facial movement. That's why we name it a locked syndrome. The patient seems to have a pseudo coma. He is not really in a coma, but he is in a pseudo coma. Uh, the oculomotor nerve is typically spurred, so eye opening and the vertical eye movement may be preserved. If you ask the patient to move or have some reaction, the oculomotor nerve is spurred because we are at the level of the pons. This differentiating it from the true coma where the pupil or the eye movement is involved. The facial and abducent nerves are paralyzed from the impairment of the cortico-pulbar tracts. So in this locked-in syndrome, the patient seems to have a locking or what we call a pseudo coma. This is called a locked syndrome, bilateral median affection of the pons. If it is a one-side affection, this is called Foveli syndrome. The ventral pontine syndrome, which is the Raymond and Miller-Jupler syndromes. This is called the alternating abducent hemiplegia. Raymond syndrome, alternating abducent hemiplegia, caused by unilateral lesion of the ventromedial aspect of the pons. This resulting in affection of the ipsilateral abducent nerve on the same side and the corticospinal tract, but sparing the facial nerve without affection of the facial nerve. The patient presents with lateral gaze weakness, ipsilateral lateral rectus paresis due to affection of the abducent nerve, and contralateral hemiplegia. The cranial nerve on the same side of the affection, and contralateral hemiplegia, which is called a crossed hemiplegia or hemiparesis according to extent of affection. The Miller-Jubler caused by lesion to the ventral aspect of the caudal pons involving also the corticospinal tract, abducent and facial nerve. So in the Raymond syndrome, we involving the abducent and the corticospinal tract with sparing of the facial nerve. If the facial nerve is affected, we call it Miller-Jubler syndrome. The manifestation also ipsilateral facial paresis with loss of corneal reflex and the contralateral hemiplegia, isotropism, and diplopia that is worsened when the patient looks towards the side of the lesion because he have a paralyzed abducent nerve, and if he looks to the side of the lesion he will exaggerate the squint or exaggerate the diplopia, and he have a more manifestation of eye movement and more manifestation of diplopia. This is the Raymond syndrome, which is alternating abducent hemiplegia. We have a central part affecting the corticospinal tract in addition to affection of abducent nerve. Abducent nerve on the same side and hemiplegia on the opposite side. If it extended to involve also the facial nerve, it will be called Miller-Jubler syndrome. So this ventral pontine syndrome is simply corticospinal tract in addition to abducent plus or minus the affection of the facial nerve nucleus. The medullary syndrome. The medullary syndrome simply, this is the MRI, this is a corresponding a diagram of for the internal structure. We have to keep in mind that the pyramidal tract in the anterior part of the pyramid, this is the olive, inferior olivar nucleus on both sides, the inferior cerebellar peduncles, and the last four cranial nerve nuclei are arranged posteriorly. We have the nuclei of the hypoglossal nerve, the nuclei of the vagus, accessory, and glossopharyngeal nerve. Okay, this is the arrangement of the nuclei in the medulla and the different internal structures of the medulla. You have to keep in mind all these structures when you think about the occlusion syndrome of the medulla. The occlusion or vascular occlusion syndromes. In generally, the cranial nerve are arranged. This is the ventral portion of the pyramidal tract. This is the olive. The hypoglossal nerve extending from the anterolateral sulcus of the medulla, while the last of three cranial nerve extending from the posterior part. The Wallenberger syndrome or the lateral medullary syndrome. It is due to insult to the lateral medulla, the inferior cerebellar peduncle, vestibular nucleus, spinal trigeminal nucleus, and the nucleus ambiguous are typically affected. This is due to involvement of the pica or the posterior inferior cerebellar arteries. This involvement of the pica results in vestibulocerebellar symptoms like vertigo, falling towards the side of the lesion. We have some diplopia, multidirectional nystagmus, ipsilateral Horner syndrome, hiccup, contralateral body loss of pain and temperature, sensation, hoarseness, dysphonia, dysphagia, dysarthria, and decreased gag reflex. This XLT2 3 Tesla for the medulla show area involved with the Wallenberg syndrome. This is the green area, posterolateral of the lateral medullary syndrome. The Wallenberg syndrome or the lateral medullary syndrome, this is the axial diffusion. This is a part representing acute stroke. We have a small bright spot here in the diffusion image, light or faint bright spot in the posteromedial or the posterolateral part, and in the axial diffusion, this is representing a small focus due to occlusion of the pica posterior inferior cerebellar artery. The second part is the Dejerine syndrome. The Dejerine syndrome infarction of the medial medulla, or this is called the medial medullary syndrome. It is due to occlusion of the small perforating branches from the vertebral artery or the proximal basilar artery, or occlusion of the anterior spinal artery, which are the parted supplying the anteromedial part of the medulla. The picture will representing by ventro-contralateral weakness and hemisensory deficit with ipsilateral hypoglossal nerve palsy. So the medial medullary syndrome, we have affection of the pyramidal tract in addition to the hypoglossal nerve. Okay, this is due to affection of the hypoglossal nerve extending in the anteromedial part of the medulla, from the anteromedial, from the anterior sulcus or the anteromedial sulcus of the medulla. This is the reverse of the lateral medullary syndrome, where there is insult in the lateral medulla involving inferior cerebellar peduncle, the vestibular nucleus, which is number 8, the spine trigeminal nucleus number 5, nucleus ambiguous, which supply 9, 10, and 11 nuclei motor part. These symptoms of dysphagia, dysarthria, dysphonia, hoarseness, gag reflex, all are considered as the bulbar symptoms due to affection of the 9th, 10th, and 11th cranial nerves. So the lateral medullary syndrome, we have affection of the lateral part of the medulla, involvement of the cranial nerves nuclei, which are 9, 10, and 11, and the patient there is a vestibulocerebellar symptoms like ataxia, vertigo, falling down, but there is no hemiplegia or hemiparesis. There is a sensory loss of pain on the opposite side of the body. while in the medial medullary syndrome, we have clear hemiplegia on the opposite side and hypoglossal nerve on the same side. And this is called crossed hemiplegia or crossed hemiparesis. The Babinski-Naguti syndrome or hemimedullary syndrome. This is simply a total occlusion of the intracranial part of the vertebral artery, which is a summation of the medial and lateral medullary syndrome, combination of both manifestation. Valvar manifestation, in addition to the hypoglossal nerve affection on the same side, and crossed hemiplegia and crossed hemianesthesia on the opposite side. To summarize, finally, we have a different syndromes for vascular occlusion, the Weber, Benedict, and Claudy syndrome for the midbrain, Mary Fox, Fouvelli, locked-in syndrome, ventral pontine syndrome for the pons. In the medulla, the lateral medullary or medial medullary syndrome, and the hemimedullary syndromes. This is a nice paper and article. You can visit from this site for further dedicated reading. I hope you all get benefit from this lecture. Thank you all for your nice attendance.